Can you please start your video? Yes, hello. Sai Shrikar, can we start?
Yes, sir. Good to go.
Sir, we start. I'll
Yes.
come back again on this mic. Hello, good afternoon, doctors. We cordially welcome you to this webinar on role of Oseltamivir in flu management. This program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is one of the largest closely held pharmaceutical company in India. Hetero Healthcare is the largest manufacturer of ARV, APIs and FDFs in the world and has Asia's largest API manufacturing facility at SCZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patient, because of which in August 2020 they received an award of Pharma Excellence for COVID drugs. Today's webinar, role of Oseltamivir in flu management, we have got Dr. Pramod Zog sir as our moderator. Welcome, Dr. Zog, and Dr. Anil MU and Dr. Nageshwar Narayan Rao as our speaker. Welcome, Dr. Anil. Welcome, Dr. Nageshwar. Dr. Pramod Zog sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee member GAVI-CSO 2016 to 19, Chairman Mini Recipe Module IIP, author of book Pathology. Dr. Anil MU sir is MBBS MD Pediatrics, Fellowship in Pediatric Critical Care, DAA Diploma in Allergy and Asthma. Sir is Lead Consultant, Pediatrics and Pediatric Critical Care from Sparsh Hospital, Bengaluru. Dr. Nageshwar Narayan Rao is MBBS DNB Gold Medalist, PGD MCH from Indira Gandhi National Open University, New Delhi, India. Clinical experiences in Nice Hospital, Hyderabad, Mahavir Hospital and Research Center, Hyderabad, and Mahadevappa Rampur Medical College, Gulbarga, Karnataka. Sir has trained graduates from Care Hospital, Hyderabad, trained postgraduate DNB students, trained nurses in NRP and neonatal nursing protocols, trained staff nurses in PICU. Sir has been faculty or instructor in pediatric advanced life support. Dr. Nageshwar has performed several procedures both in neonates and children and has presented in many seminars and conferences. Welcome, Dr. Nageshwar, and welcome all of you. With this brief introduction, I hand over the session to Dr. Pramod Zog, sir. Over to you, sir.
Thank you. I just share my screen.
Yes, sir.
Okay. Is the screen visible?
Yes, sir.
Thank you. Thank you. Thank you. Okay. So, good afternoon, friends. We are going to discuss an important topic, the use of Oseltamivir in flu management. And I am glad to have Dr. Anil and Dr. Nageshwar Rao for this particular session. And we will discuss related to influenza and Oseltamivir in as much details as possible. All of us are aware that respiratory infections are the bread and butter of a practicing pediatrician. That's also one of the important causes of admissions in the pediatric wards, and those who get serious get into the ICU. And to differentiate one respiratory infection from other many times is very difficult. However, the management related to respiratory infections or the respiratory distress more or less remains the same, except for the choice of antibiotics and other minute details about the management. We are going to discuss more about influenza today, though we will touch upon certain other respiratory infections during the flow of this discussion. You can see that the influenza virus has a particular nomenclature, and just to make the thing simple, I have put my name in the fashion of influenza nomenclature, which includes the place of origin and the year of detection and so on and so forth. And as far as I'm concerned, I was the IIP presidential strain in 2016. You know that every year the influenza virus strain changes. On the same lines, the strain of the IIP presidents also continues to change. Of course, that's in a lighter vein. And come monsoon, it's all influenza everywhere, particularly in majority of the parts of our country. We have influenza very, very common during monsoon. And these are the months, usually June, July, August, and September. However, in certain areas of our country, like Kashmir and Kanyakumari, the monsoon sets in little later. And in those areas, it is in the latter part of the year. It's not only influenza, but there are other viruses like the respiratory syncytial virus and even arthropod-borne illnesses like dengue. They make their appearance, and even though malaria is on decline, that was one of the important parasitic infestations which was known during the monsoon. So monsoon basically is a period when I always say that the farmers are happy, the frogs are happy, the pediatricians have been happy because of the rise in the viral illnesses, and the pharmacists are happy because the sale of the medicines is on the higher side. Anyway, so whenever a child is brought for a viral illness, wherein a pediatrician suspects that it is likely to be viral, gone are the days when we were, relaxed and used to say that don't worry, it's viral, because the days have changed, particularly after the 2009 pandemic of influenza and the COVID pandemic. We now know that there are things like cytokine storm, which can, totally disrupt the sleep of a practicing pediatrician, physicians, and so on and so forth. And what has happened is that during the COVID times, the immunity of children, immunity of adults did not develop well because everyone was indoors. And that's why after COVID, these respiratory infections and other viral infections, they have shown a rise, what we call as immune debt, which was there during the COVID times. And that's why we have seen so many respiratory infections and associated problems related to the upper respiratory tract rising in the post-COVID era. And what we have seen is even the older children are getting affected by these viral infections. After the COVID started declining, we saw RSV, we saw adenovirus. In areas where measles vaccination was on the lower side, we saw even measles cases in higher proportion, hand, foot, mouth disease. So all those illnesses, they have shown a rise after the COVID pandemic. We will start our discussion with a case, and this is the case of a 3-year-old boy who came with fever, cough, cold, and progressive breathlessness over 3 days. The child was tachypnic, hypoxic, and the X-ray of the chest showed a picture suggestive of acute respiratory distress syndrome. Obviously, the child was admitted to the PICU. In view of this clinical situation, we received oseltamivir, the antiviral agent, along with supportive therapy, and the throat swab reported H3N2 positivity. This child was ventilated for 3 days and then he improved. It appears, that everything went on well, but everyone started thinking whether this particular progression seriousness could have been prevented by early use of oseltamivir. And that's why in a previously healthy child presenting with cough, cold, and fever progressing over 3 days, whether a treating clinician, can prevent this particular progression. And some of these areas of confusion, these are the points of confusion in related to flu. They include, the diagnosis, whether it's bacterial or viral. We know that viral illnesses in general are generalized. They affect many of the systems of the body, while bacterial infections are localized. In case if we feel that it's viral, what is the type of virus? Whether we can have some educated guess about the type of the virus. If at all we feel that influenza, whether this is H1N1 or whether this is H3N2, and whether we should use oseltamivir. So all these questions, are important, and we'll try to find out the answers with the help of our experts today. So all of us are aware that in monsoon there are quite a few healthcare related challenges, and influenza is the father, the most important illness of all the influenza-like illnesses. The short form for influenza-like illnesses is ILI, and we have a categorization of these illnesses which we will discuss. And the influenza incidence and the related deaths have been increasing alarmingly in India over last few years. There are three types of influenza viruses: influenza A, B, and C. and it is necessary that we know the KYC, that is the know your customer, related to this influenza. Why I call this influenza virus naughty? Because it changes its structure every year. In fact, RNA viruses are known to change their structure. So the COVID virus, the RSV, the influenza virus, all these are RNA viruses. We all are aware that viruses are either classified as DNA viruses or RNA viruses. However, to survive, we require both these RNA as well as DNA, and that's why when a virus doesn't have one of them, it depends on someone else to survive, and that's why these RNA viruses get into the human beings or the animals or the birds for their survival. Influenza A is responsible for frequent epidemics. The outer proteins of this virus, they always change. Every year they change. There are glycoproteins which have amino acids, and the variation in these amino acids produces, minor changes in the structure, and that's why every year we have to have a new strain of the virus in the vaccines also. And influenza B, on the other hand, infects only humans. Influenza A can infect birds, animals, as well as human beings, but influenza B remains to only human beings and produces local epidemics. As I was trying to tell you, the influenza virus, particularly hemagglutinin and the neuraminidase, which are the two important glycoproteins on the outer side of the influenza virus. These are two glycoproteins, and hemagglutinin is the one which is useful for the virus to get attached to the respiratory epithelial cell. So when the virus enters from the nose and then goes down to the trachea and the bronchi and then to the lungs, all the parts of the respiratory system it can involve, it will get attached to the respiratory epithelial cell with the help of this hemagglutinin, and the RNA of this virus will enter into the respiratory epithelial cell. After entry, this RNA will dictate the DNA of the host cell, that is the respiratory epithelial cell, and produce similar copies, similar RNAs in plenty. And these virions or the viral particles need to be separated. So neuraminidase is the enzyme which acts as a molecular scissors, and these RNA particles, the viruses, the virions, they are separated and then they are released, and they are ready to infect the other respiratory epithelial cells. The molecule that we are going to discuss today, oseltamivir, is the one which is neuraminidase inhibitor, which will block the action of neuraminidases, and that's why the release of these virions into the other part of the respiratory epithelial cells is prevented. And for the information of our listeners, they should be aware that there have been some major global pandemics related to influenza in 1918, 1957, 1968, and 2009. And H1N1, H2N2, H3N2, H1N1, all these viruses, they were influenza A viruses. And every time they had shown a major change in the structure, and that is called as a shift in the epidemiology. So, Dr. Anil, I would just like your opinion about the epidemiology about the circulating strains of influenza viruses in the pediatric population in India.
Yes, sir. Thank you. Thank you very much, sir. Good evening. So, over the last few months after the onset of monsoons, I think all of us did experience a uh, increase in the number of cases of the flu. Probably this started in the June, July after the monsoons hit us, and now it's kind of receding. And now we are heading into the winter, where we get the second peak of the flu season, which is just about starting. So in India, what happens is majority of the flu viruses are there during monsoon, and then a small second peak happens now towards November, December, and Jan. There is a second slow peak which happens. And what we saw in this season was that we saw more of H3N2. We saw more of influenza A. Sir has already told us the KYC where there was influenza A, influenza B, and other viruses. In that influenza A H3N2 variety, we saw quite a bit. And the H1N1 PDM09, that's the pandemic which was seen in pandemic 2009 type. This also we saw probably less in number. Very small number of influenza B also we did see in this season. So I think majority it's been H3N2 over here, sir.
Right. Thank you very much. And Dr. Nageshwar, in your area like Bidar, do you get an opportunity to get the isolation of these different kinds of viruses in the
Uh,
practice?
no, sir, because we stay in a resource limited setting. Only patients who are sick enough and we refer them to higher center like nearby Hyderabad. There they will get some multiplex PCR or biofire done. Of the few cases which we have sent there, we have found RSV and adenoviruses in the throat swab, sir. When the
Okay.
patient come back to us for follow-up, when we go through the reports, we get to know those reports as those positives.
Yeah, perfect, perfect. So this influenza virus, as we all of us are aware, that it spreads to others up to about 6 feet away, and these viruses spread mainly by droplets when people cough or sneeze, and the droplets land in the mouth or the nose of the people who are nearby, and then they are inhaled into the lungs. Dr. Nageshwar, what all different clinical scenarios you came across with influenza in the pediatric population during this particular season?
Sir, like usually in a family of 2 or 3 kids, when one child is going to school, there they usually contract an infection which presents with the acute onset of fever, cough, associated with some throat pain. If the child is older enough to explain the symptom, then they will tell about the sore throat, along with that myalgias, headaches, dull activity, not feeding well. And if the child is not got early medical attention or medication, then they would have landed in complications also like delirious states, seizures, encephalopathy, or a sick child getting admitted into ICU for respiratory distresses, sir.
Yeah, you're right. And as we discussed earlier, and I said that influenza is the father of all those influenza-like illnesses. What I meant was that the systemic presentation, like headache, severe body pain, weakness, that is much more in influenza as compared to other illnesses. And we have seen many times, the father lifting even an older child, like 9, 10, 11-year-old, and bringing to the clinic. That's all related to the weakness. Many of these presentations are related to the cytokines also, and we will see in the course of discussion about some complications also. Dr. Anil, have you come across any complicated cases of influenza?
Yes, sir, we do, because ours is a little referral center and we do take care of kids in the ICU. We get referrals for sick patients, and majority this season has been mainly for the respiratory cases. On day 4, day 5, when it is not picked up, not treated with the uh, Oseltamivir molecule, if it is flu, then they'll land up with respiratory distress and all that. And we have seen other cases also, like very rarely they are coming with a neurological manifestation, like what sir told. Because of the high grade fever and sudden onset, there is increase in incidence of febrile seizures and febrile delirium. Little older children are brought with very high grade fever and they're delirious. And some of them don't regain their sensorium between the seizures. So that's a febrile encephalopathy kind of a situation also we have seen. Also, we have seen few cases of acute necrotizing encephalitis also. And of course, we have seen other progressive illnesses like multi-system involvement, in that is the liver involvement, the renal involvement, myocarditis. All this has been described, but not commonly seen. I think we see more of CNS and the respiratory complications, of course.
Sure. As we were discussing earlier, there are quite a few different presentations related to the respiratory viruses. There are influenza-like illnesses, H1N1, severe acute respiratory syndrome, and COVID-19. And many times it's difficult to differentiate one from other. However, there are some indicators, like for example, during COVID-19, we had patients who came with loss of smell, loss of taste, and so on and so forth. And there are certain warning signs which we may call as emergency warning signs, which the pediatrician also must know, and the parents also should know. So now that Dr. Anil, you are in the emergency settings in the ICU, and you have been seeing so many cases of influenza, I would just like you to tell our listeners as to what are the so-called red flags or areas where one should be worried, and whether a pediatrician should inform the parents that they should bring the child back to the casualty in case if some of these things they happen. Yeah.
Yes, sir. These red flag signs are the emergency signs, which I think the parents also should be aware. we know that the influenza is mostly a self-limiting viral kind of illness. Majority of the cases, it settles down on its own by day 4, day 5. But when we are seeing a child on day 1, day 2, we are suspecting influenza. We should always educate them about these danger signs. The best sign that we can look at as a parent, what they can look at is how is the child behaving in the interfebrile period? Is the child becoming active? Is the child able to maintain the oral intake? Child is able to eat and feed himself or herself and maintain the oral intake? How lethargic the child is going to be? How drowsy the child is going to be? And system wise, if we look at it, they should also watch out for if at all there is any shortness of breath, fast breathing, or severe bouts of cough which is not abating, these kind of things. And neurologically, how active the child is, how drowsy the child is, if at all there is any seizure. And perfusion wise, they should look at any cold clammy peripheries or less urine output. These are the routine danger signs which we educate the parents about in any illness for that matter, more so in the flu because the onset can be dramatic.
Right. It's very important that we are aware of the complications of influenza, which are most commonly respiratory. And so, respiratory rate and cyanosis are to be definitely seen. These days, people do have pulse oximeter, and even parents used to have this during COVID time, so they can even measure the oxygen saturation. And there are some complications, as we said, like involvement of the CNS, so their sensorium can be monitored, and myocarditis, which is rare, but then during this particular season, we had one case where the tachycardia was disproportionate to the fever. So, we could suspect myocarditis. Of course, the child fortunately came out. And then, of course, some complications related to other systemic involvement. We'll discuss about it in further details later on. So, this is very important. And then the complications, can be grouped under, certain things starting from alphabet A, like ARI, which includes pneumonia, which could be primary viral pneumonia directly related to the influenza virus, or ARDS, which could be related to the cytokines, and acute otitis media, which is also a known complication. These viruses usually they destroy the respiratory epithelium, and that's why the bacterial infections can set in, and that produces secondary bacterial infections. All these problems, keep the child away from the school, and that's something which leads to school absenteeism and loss of income for the parents. And as there is a lot of confusion about the bacterial, viral, and so on and so forth, there is a lot of antibiotic abuse which is associated with influenza. Now, for simplifying the management of influenza and influenza-like illnesses, there has been a traditional way of categorizing influenza into categories A, B, and C. And Dr. Nageshwar, will you be, able to tell our listeners about this categorization as to what is the basis, and then we will go to the management part of it. Yeah.
Uh, Regarding this category A, like we can consider it as category A, B, and C is like mild, moderate, and severe symptoms for easy understanding, sir.
Yeah.
When we go deep into that, category A is like any child who is presenting with mild grade fever, little bit of dry cough with or without headache, body pain, and vomiting. Relatively, the child condition is stable, and in interfebrile period, the child appears to be relatively active, sir. When coming to category B, this is little bit more complicated than the category A. Here, the child usually have a high grade fever with severe throat pain. Along with that, along with the above symptom, child does not look to be as stable as in category A. This child usually can be categorized into category B, sir. Along with this, coming to category C, this is a severe form of disease where the child's systemic involvement is there, where they present with a high grade fever, delirious state, sometimes with complications like seizures, respiratory distress, and usually sick child presenting to ICUs.
Yeah, right. And then, of course, this category B also includes, those people who are at a high risk, like particularly children under the age of 2 years, or, pregnant women, or, elderly above 65 years, or those with some existing problem related to the heart, or someone who is on steroids for nephrotic syndrome, or those who have some malignancies like leukemia, or those who are suffering from HIV. So there are some categories then, which are grouped under category B. this particular categorization is very important for managing the child. So before we go to the management, I will just explain a bit about this molecule called oseltamivir, and that's a neuraminidase inhibitor. And as I told you earlier, it blocks the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cells. Basically, it's a prodrug which is converted into the active form oseltamivir carboxylate in the liver, and this was the first oral neuraminidase inhibitor. It has been approved in more than 100 countries, also approved by CDC and the American Academy of Pediatrics. And as we discuss the categories, I will like Dr. Anil to explain about the therapy based on this categorization.
Yes, sir. I think just for simplicity, we will remember category A as our normal OPD patients that we see. These are the simple walking, talking kind of patients who come to us to the OPD. They have very mild symptoms. They have fever, cold, cough, coryza. For them, it's a self-limiting illness. In this category, there is no need to test, and there is no need to start them on specific antiviral therapy also. Just symptomatic supportive care of giving some paracetamol for the fever, good hydration, and educating the parents for these danger signs. This should suffice, and child is always fine after 4 to 5 days, as it's a self-limiting illness. Category B, which is more severe symptoms than category A, and will include all the other high-risk people. These are the ones where again treatment is definitely indicated with the molecule oseltamivir. Testing may or may not be done based on the presentation and what is the clinical scenario. Based on that, the testing decisions can be taken. But these are the ones where we need to empirically even start them on oseltamivir, and of course continue with the symptomatic supportive care and also explain them the danger signs. Category C are the ones who are moderately to severely sick ones who will end up in our ICU or in the HDU kind of an area. So these are the ones definitely we admit them, monitor them very meticulously. The monitoring is done. And these are the ones, again, they are started on therapy with oseltamivir. And of course, these category C are the ones where we need to test them for the flu for epidemiological understanding of what is happening, which virus it is. We test them. Definitely, we do test category C for the with the swab.
Sure. Let's uh, methodic approach to the management of influenza, and the dosages and the recommendations for oseltamivir have been very, very clearly mentioned. So for adults, the dose of this molecule is 75 milligrams capsule twice daily for therapy, that is for treatment. And if there is, an indication where we need to prevent influenza in someone who is in the family, like as I said, some of these high risk conditions, then the dose is 75 milligram capsule once daily, and it's for 10 days. In children, the dose has been dependent on the weight bands ranging from infancy up to above 40 kg. For children, there is oral suspension available, which is available as 12 milligrams per ml. And in the infants, the dose is 3 milligrams per kg. Again, the therapy is given in the twice daily dosage form, while chemoprophylaxis is given in once daily form, and that is for 10 days. Dr. Nageshwar, when a child is brought to us and when we suspect influenza, how early, you would start oseltamivir, and whether early initiation of oseltamivir has an influence on the clinical outcome. What is your opinion?
Yes, sir. Actually, if there any child who has come in a category B, if the clinical scenario is setting enough, then oseltamivir is added, sir, within the first 48 hours. As we have read in the previous studies, like if we introduce oseltamivir during the treatment course in the first 48 hours, there is the significant reduction in the associated complications like pneumonia, encephalitis, secondary bacterial infections, and even hospitalizations also. So, for IPD patients, studies have indicated that oseltamivir can be started even on fourth or fifth day of illness. Even if you introduce late, also it will give benefits, and in the form of reducing the disease severity and to prevent the complications also.
Sure. So even if the patient comes little late, it will be prudent and wise to put this child on oseltamivir because it is known, yeah, it reduces the complications, hospitalization, and even the mortality. And this has been proved in quite a few clinical trials that the molecule oseltamivir reduces the antibiotic use, influenza-related low respiratory tract complications, and also hospitalization. And this is not only true for children but also for adults. And the WHO recommendation says that empiric treatment is strongly recommended. The treatment should be started as soon as possible. The laboratory confirmation of influenza virus is not necessary for initiation of therapy. And we will have a look at some cases which we face commonly in the OPD. Dr. Anil, this is a child who has come to us for fever for 3 days with cold cough. The child has been on metered dose inhaler since 4 months. He has been well controlled with this and has received symptomatic therapy for the current illness. He has been well for a day, febrile, and then after 3 days, he comes back with fever. In general, he has been active in between, and the parents are worried that this particular child is having recurrent viral infections now. Of course, we know that they are more frequent now and they occur at shorter intervals. And many a times it's a dilemma for the practicing pediatrician also as to what to do, whether we should start antibiotics. And I would like you to, just tell our listeners as to what should be our approach when we come across such children.
Yes, sir. Whenever we are seeing such children in our OPD, nowadays it's become very, very common scenario. I think as and when we are giving more vaccines, the bacterial infections have come down, and we are dealing with more and more children who are coming with such recurrent viral infections. Probably like in the beginning, like what sir told, because of the COVID, there is a lot of immune depth which is there. And because of that, we are seeing that children are now coming with recurrent viral infections. So this is a common situation where I think we should spend those couple of extra minutes with the parent, counsel them, telling them, see, these are all minor viral infections, what the child is picking up probably from the play group or from the school. And this is how the immunity builds. There is nothing like a ready-made immunity for the child. And every time the child comes across a new virus or a new bug, the child may go down for a day or two, but not to worry. We'll show them how well the child is growing on the growth chart. We'll plot it on the growth chart. We'll counsel them, telling them that the child is growing fine. We'll also explain them all the danger signs. None of the danger signs are available. And probably if they're still not convinced, we will categorize into category A, B, and C. Your child is still in the category A, which is a self-limiting viral kind of illness. So we'll always call them back in 48 hours to reassure them that the child is doing fine. I think spending those couple of extra minutes with the parents will go a long way in counseling such parents.
Yeah, that's great. And then Dr. Nageshwar, at your end, do you come across such parents who rather would like to know as to what should be done? And because in major cities like say Bangalore or maybe Mumbai and others, it's possible that the parents are over anxious. But then at Bidar, do you come across such parents who are worried about the repeatedness of these respiratory infections?
Yes, sir. Not to a higher extent, but few parents are over anxious. Uh, Again, we follow the same told by Anil sir. We counsel, we take little bit of time out of our OPD and we'll counsel the parents. Like as the child is recovering fast in 2 to 3 days from any viral infection, and the child is getting somewhere around 10 to 12 episodes of acute respiratory infections in an year, and growth is normal, development is normal, we ask them to just give supportive treatment only. In any
Right.
case, child is anemic, any malnourished, in any group of severe acute malnutrition, then we'll emphasize like once this illness period is over, you please focus on improving the nutrition and anemia in a child so that the child's immunity will increase and the repeated episodes of infection or any small infection which is prolonging due to anemia or any malnutrition are covered.
Yeah. I think that's an important point, related to, malnutrition because, the vitamin A deficiency and other, trace metals which are related to the health of the respiratory system in general, they are also important. And it's possible that once the child recovers, you should take care of the nutrition part of, the child's health so that these recurrent infections are avoided. And the management of respiratory infections in a child who has severe acute malnutrition also is quite different. And that's why one should be aware that, not that only we maintain the growth chart, but also measure the mid-arm circumference. And then in case if the child falls in the SAM category, it is more important to advise the parents about the nutrition. I am glad that you brought up this point, and it's, I think, quite relevant to the sector of our patients, which is likely to be affected by malnutrition, right? And it's also important that we are aware of some of these points related to the educated guess about some of the viruses and the bacteria. Like we know that rhinoviruses usually affect the upper part of the respiratory system, like the nose, and these children are playful. They are not exhausted. They may get fever, they may not get fever, and it won't probably be a serious illness. Influenza, we just saw that it comes with high fever, prominent headache, myalgia, and extreme exhaustion. Viruses like adenovirus, may present a bit differently, though basically it's a basic respiratory virus. It can come with pharyngoconjunctival fever, diarrhea, sometimes mesenteric lymphadenitis, hemorrhagic cystitis. And RSV can come with bronchiolitis, particularly under the age of 1 year. And bacteria like group A beta hemolytic streptococcus can come with follicular tonsillitis and tender cervical nodes. Pneumococcus can come with pneumonia, which can present with grunting and tachypnea along with fever. And staphylococci, can produce progressive pneumonias, which are rapidly progressive, and the child is likely to be more toxic. And we all know that mycoplasma affects little older age, and then they present predominantly with cough. So a knowledge about the organisms and the clinical presentation will help our colleagues to some extent in the management. Now, Dr. Anil, this is another child, 4-year-old, who came for cough and fever of high grade since 5 days, was not settling with oral medicines. On admission, he had tachypnea and needed oxygen support. This is the X-ray of the child, which shows you some lesions on the right side of the lung. The hemoglobin was 11.6, total count was 1620. The platelet count was 1,32,000. The liver functions were deranged to some extent, and the nasopharyngeal aspirate showed positivity for H3N2. We diagnosed it as a case of influenza with low WBC count and the low platelet count. This is a scenario which is quite common in the day-to-day practice, and our listeners would be happy to know as to how one should approach a child presenting with such symptoms and signs. Yeah.
Yes, sir. This is a very, very common scenario where we got referrals in this state. Usually they would land up to us on day 4, day 5, once the complication starts or when the respiratory distress start. For example, this child, 4-year-old, is coming to us on day 5 of fever. And at admission itself, the child has got red flag signs. That is, child is tachypnic and already requiring an oxygen support. So this is straight away in category C kind of a patient. So in category C patients, we would admit them probably depending on the case to case basis, either in the HDO or in the ICU, depending on the oxygen requirement and in the and looking at the distress. And this child has already developed little infiltrates on the right side. So as and when we receive the child, we won't know what is happening. So sick child definitely deserves to be admitted. We will start an IV cannula, probably collect the blood culture. Sick child, we will definitely go ahead and start on IV antibiotics according to our respiratory protocol that we have. And with the backdrop of monsoons or increased cases of influenza A in the community, we should not be forgetting the molecule oseltamivir. This is the category where even before we get any of the blood tests or the nasopharyngeal swab, because the blood test may take another 2-3 hours for the reports to come back. The swab may take up to 24 hours for the swab result to come back. So we don't wait for it. So these are the cases where upfront we go ahead and start them on the molecule oseltamivir with the epidemiological evidence of increased cases of influenza in the community. We go ahead and start. So once probably we get the lab, here it showed there is a leukopenia, total count of 1600, and the platelets are also borderline. Again, kind of telling us it could be a viral, primary viral kind of a pneumonia. And once we look at the transaminases, which are slightly elevated, again points in terms of a probably viral kind of an etiology. And this situation, especially the backdrop of monsoons, we are seeing cases of dengue also. We should not be forgetting our old friend dengue. This year we have had less cases of dengue here in Bangalore, but we should not be forgetting dengue, because sometimes there can be a coexisting dengue also. Even though the mode of spread is different, the child can have a dual infection. And of course, the nasopharyngeal swab, which comes after 24 hours, or if the center is good, the swab is sent in the morning. By late evening, we may get these reports. So that kind of confirms the viral etiology. So this is typically how we saw our influenza-like illnesses in this season. This is how it presented.
Right, right. And Dr. Nageshwar, do you have anything else to add to what Dr. Anil has said? Maybe in a resource limited setting where the swab is not possible, and where the parents may not be from the affording category. What is your approach in such situations?
Right, sir. Here again the molecule remains the same. Only thing is like we start the oseltamivir empirically along with the antibiotics also. Once we get some routine blood investigation, hematological investigation, then we can modify the course of treatment. Otherwise, we usually follow the same protocol, sir.
Okay, excellent. So we had similar cases during this season wherein a child, 3-year-old with cough and fever for 5 days, where fever was not settling, and the counts were normal, and it was H3N2. There was another one where CRP was 38 and the child had H3N2. Of course, there were a few cases where the throat swab showed adenovirus positivity, but this child had high WBC count and high CRP of 136 and had continuous high fever. Of course, adenovirus has deceived us rather on many occasions where it has presented even with lobar consolidation. And there was one case of human metapneumovirus which also presented with lobar pneumonia like presentation. Dr. Anil, this is a child 5-year-old with high fever for 5 days, cough and cold for 5 days, is sick and has mild wheeze and no crepitations. I would like you to tell us whether you would put this child on antibiotics, and I will tell you the further, management of this child. So, on the front of this case, how would you approach this child?
Yes, sir. Again, this child is coming to us on day 5 of illness with still high grade fever going on. So if it was a simple viral illness, it would have been a self-limiting illness. Probably the child would have got starting to get better at least by day 5 of illness. And also by the description that it says that the child is sick and having a mild wheeze. So I think this child, we need to go ahead and start on antibiotic in the beginning, and then we can take a call later on based on the other evidence that we get. But if at all there is a influenza like illness which is already going on in the family, and the child comes to us with other coryza, cold, cough, kind of a prodrome, and that is progressed, I think it's okay to wait on oseltamivir. Again, depends on case to case basis over here.
Okay, so this child was put on amoxiclav and the WBC count was 2800. The neutrophils 10, lymphocytes 70. The CRP was 34.7. The child was put on oseltamivir and nasopharyngeal swab turned out to show rhinovirus as positivity. So, Dr. Anil, what is your opinion about the sensitivity of influenza PCR and treatment decisions?
Yes, sir. With the backdrop of this community influenza that's going on, here we have found out that there is a rhinovirus in the nasopharyngeal swab, but it is not matching the clinical scenario which is present. It's a big girl, day 5 of illness, and the child is looking sick. Whereas a rhinovirus, we would expect a localized kind of illness, more of coryza, cold, cough, and probably a mild viral illness, viral febrile illness, and it will get better. So probably this is just about there, in the sense it may be a co-infection or it is still there. Coming to the sensitivity of the PCR tests which are available, the latest generation of PCRs are quite sensitive to the extent of being more than 95% sensitive, if the caveat being that the swab is collected very well from the nasopharynx, pretty deep in the nasopharynx. The sensitivity is quite good and it is able to pick up these influenza group of viruses. So coming to the treatment decision that we make, if our clinical acumen and the clinical syndrome is of that of a acute febrile viral kind of an illness, and there is no other reason, or there is no other way to explain this illness. That means there is no lobar involvement, and everything is pointing towards a viral kind of an etiology. I think we should still go ahead and continue this child on the molecule oseltamivir against the influenza A in such a situation.
Sure. Uh, Now, Dr. Nageshwar, this is a 7-year-old daughter of IT sector parents and has come with high fever for 3 days with throat irritation. The child has her school exam after 2 days, and the throat is showing mild congestion. The child has been put on paracetamol. The flu and the adenoviral, epidemic, so to say, is going around, and the parents are worried. And as they are from the information technology sector, they are more worried about this child, and they want to know as to whether we need to investigate, whether a throat swab needs to be sent, whether the child needs to be put on empiric oseltamivir, and they have so many questions. So how would you approach such a case?
Sir, being a child at 7 years, definitely she'll be going to school and she will have multiple social contacts in school. And with the history of flu and adenovirus epidemics going on, there are very high chances that child may be contracted with the viral infection only. Again, there is a history of high grade fever of 3 days along with throat irritation, which suggests again on child is infected with the ongoing viral infection. There is a one issue of exam in 2 days. So it means the parents have visited the hospital only to make the child better by the day the exam is there. So on examination, there is only mild throat congestion. The child is already on paracetamol. In such a situation, if parents are insisting for test and child is also looking a bit sick, then definitely will go for a investigation, sir, because parent satisfaction is also important along with the treating the child. So definitely we'll go for CBC, CRP, and throat swab. With the backdrop of the ongoing epidemic, we'll not wait for the test result to arrive. We will start on empiric oseltamivir. As in the previous studies, we have seen that within, if we start the oseltamivir as early as possible, the recovery is fast and the incidence of complication is also less. So with this background, early oseltamivir will not only help the child in early resolution of symptoms, and she will be able to attend exam with a good health.
Okay, I can understand your viewpoint. Dr. Anil, do you agree with the viewpoint of Dr. Nageshwar?
And I'll take a different stand on this case, sir. Probably we should address the parents' anxiety over here. I think the syndromic classification of category A, B, and C, I think if we revisit that, so this child is still falling in category A, and we saw that majority of these viral infections are all self-limiting kind of a thing. So we can always show, if the parent is not convinced, we can even show them the categorization and tell them your child is still in category A. There are no red flag signs. And if at all the child worsens, we are always there around. You can please come back to us in a day or two. We'll reassure them. Probably if it's really, really pushed, probably we can ask for a throat swab and probably reassure them and send, sir. We'll try to do that as much as possible. Oseltamivir may not be indicated in the category A.
Okay. So now this is another 3-year-old boy coming for cough for a week, high fever for 3 days, crepitations. The child has been put on coamoxiclav and admitted for persistent fever. This child has been put on IV amoxiclav. The counts are more or less normal. CRP is within normal limits, and the throat swab is showing influenza A positivity. That's why oseltamivir also has been added. Now the child already was on IV amoxiclav, and now oseltamivir has been added. So, Dr. Anil, what would be your strategy about the antibiotic therapy which the child has started receiving? Will you like to continue? Whether will you like to withdraw? What is your way to look at it?
Yes, sir. Just now we discussed that the sensitivity is very good. More than 95% it detects the flu being positive. So whenever we have a positive swab test, and also that we see that the blood tests and the CRP is more in terms of a viral kind of an infection. So I think with all confidence, we should go ahead and stop the antibiotic. So this is a question of antimicrobial stewardship over here. I think, however soon we start, the same way we should de-escalate also when we have a diagnostic test which is flagging it's a viral thing. I think we can stop the antibiotic in such a situations.
Okay. And Dr. Nageshwar, now that suppose if you don't have the availability of the swab at your area, and if a child presents to you in this way, how would you go ahead?
Sir, in such a situation, anyway, IV antibiotic was already started. Even oseltamivir was also added. In absence of the tests, we would like to continue antibiotics for minimum of 3 to 5 days, sir.
Okay. And I'm sure you will like to continue oseltamivir for 5 days,
Yes,
as it is.
yes,
Yeah. Okay.
yes.
So, as Dr. Anil has rightly pointed about the antibiotic stewardship, it's very important that at least we do not escalate these antibiotics dependent on the clinical presentation and laboratory reports. During this season and in the last 1 or 2 years, there have been quite a few cases where there was involvement of the CNS. So, Dr. Anil, there was a child who was 1 year old with fever, cough, cold, and came with status epilepticus. And the report was H3N2 positive, and the MRI showed non-specific changes of encephalitis. The CSF was normal, and he was diagnosed as a case of influenza encephalitis. I would like you to tell our listeners about some neurologic complications of influenza.
Yes, sir. Like we discussed, because of the sudden onset of high-grade fever, we see that more and more cases of febrile seizure are reported during this epidemic of the flu. And few of them are treated in the ward, few of them in the OPD basis, but few of them, because of the repeated seizures, they may get admitted to the HDU kind of a situation. Febrile delirium we have seen, and also like febrile status epilepticus and acute necrotizing encephalitis also we have seen. Like what happened in the previous case, the virus is usually demonstrated in our nasopharyngeal aspirate or in the samples which is collected from the nasopharynx only. Whatever the CS effect which happens, it's all immune mediated or a cytokine mediated kind of a thing. So obviously when we do an LP, the CSF, it's going to be the CSF cell count is going to be normal only. These are all mediated by the interleukin 1 and 6. So we do see that the CNS takes a hit. Many a times we have seen deep nuclei in the CNS, like our thalamus getting infected, just like our JE kind of a situation in the CNS. We have seen the central necrosis also in few cases. And the prognosis is usually pretty bad whenever this acute necrotizing encephalitis happens. And even if they improve, they'll be left with some deficits most of the times. And of course, we have seen few cases of GBS or GBS mimicking kind of a situation also. And aseptic meningitis is also very common in this season of influenza. Aseptic meningitis cases are also seen.
Okay. And of course, there have been cases of influenza with co-infection with RSV, and there have been some respiratory complications in addition to otitis media and pneumonias, which we discussed earlier. There have been cases where there was exacerbation of asthma and some cases of acute laryngotracheobronchitis. And of course, there have been reports of toxic shock syndrome, myocarditis, which we said in the earlier part of the discussion. Myositis is seen more with influenza B in boys who are 6 to 9 year old, where there is bilateral gastrocnemius and soleus involvement, and who present with severe bilateral calf muscle pain and inability to walk, and hepatic complications like Rye syndrome were very common in the earlier years when a child with influenza B was administered salicylates, and the child would develop a picture akin to liver cell failure. There are a few quick questions for both of you. Dr. Nageshwar, there are two children in the family. The elder one is admitted with influenza A, and the younger one now develops fever since yesterday evening. What do we do? Shall we put this younger one on oseltamivir? This child who is under the age of 2 years.
Yes, sir, it is prudent to start because the anyway
Yeah.
we have a history like older child on fourth day of illness has come influenza.
Yeah. So it is prudent to put this particular child on oseltamivir because this child is under the age of 2 years and also falls in the high risk category. And Dr. Anil, in case if a child is not accepting oral medicines, is there any alternative?
No, sir. Currently, we don't have any alternative to oral form of oseltamivir. Only the oral form is available. And generally, also the acceptability and palatability has been reasonably all right. Only few cases may present with nausea. That also settles with 1 or 2 doses. Currently, we don't have any other form of this medicine right now.
Okay. You can also tell us about the chemoprophylaxis to the household contacts and your opinion about it.
Yes, sir. Again, chemoprophylaxis should not be extended to everyone who is healthy. Like in healthy adult, it is not indicated. Whereas if at all we have any high risk people, because influenza is one illness which spreads from children to the adult, so we should be very careful here. So anybody who is falling in high risk, for example, anybody who's aged more than 65, they have diabetes, they have a chronic heart condition, they have a chronic lung condition, they're on steroids, immunosuppressed for whatever reason, or less than 2 year old, and obesity. In this world, I think we should not be forgetting obesity also as a high risk factor. So all these high risk people should receive chemoprophylaxis, whereas the healthy adult contacts can be excused from the prophylaxis.
Sure. So, till now, we have seen that this particular virus is a fast and a furious virus. The onset is abrupt, the transmission is very rapid, the progression is rapid. Complications like ARDS, they develop very fast, and medicines like oseltamivir also need to be started very fast. Okay, and we are all aware of the preventive measures like sanitization, mask, and social distancing, along with following the cough etiquettes like coughing in the elbow and following certain sutras, the rules related to the hand, like washing the hands frequently, avoiding handshakes, using the handkerchief, keeping the contacts at a hand's distance, and avoiding hand touching. Remember that these viruses are definitely the respiratory viruses, but then the transmission can occur through fomites, and that's why they can get themselves onto the laptop tops or the staircases and the door handles and handkerchiefs and so on and so forth. So one has to be very, very particular, particularly the medical fraternity, the staff, the nurses, all have to be very careful. And also, all these people related to the health sector need to get themselves vaccinated against influenza by annual influenza vaccination. So it's better to remember the slogan "Happy Birthday to You," followed by "Happy Birthday to Flu," so that we prevent influenza, because the strains, they change every year and the immunity wanes, the vaccine related immunity wanes after 5, 6, 7 months. That's why it is better to get the influenza shot every year. And with that, we come to the end of this particular lively discussion. And I bid farewell to all of you by saying namaste. And of course, being a online meeting, I will have to say namaste from here only. And of course, we will also learn to avoid handshake so that we avoid the transmission of the viruses like influenza and others. Thank you very much. It's over to you, Dr. Prashant.
Thank you, sir. Thank you very much. Thanks, Dr. Anil. Thanks, Dr. Nageshwar. Thank you, sir. Very lively session.
Thank you,
I'm
sir.
sure
Thank
the
you so
audience
much.
has benefited. Thank you. Thanks,
Thank you,
Sai Sridhar,
Nageshwar
for
sir. Thank you
listening.
so much.
Thank you.
Namaste.
And
Thank you.
namaste to all. Thanks
Thank
all
you.
the audience who took time from the scheduled and attended this. Thank you, Sai Sridhar, for your IT support. Sir, we can sign off. We can
Thank you,
go.
sir. Thank you.
Thank
Okay,
you.
okay. Thank you, Dr. Nageshwar. Thank you, Dr. Anil.
Thank you.
Thank you, sir.
See you
Thank you
soon,
so
sir.
much.